So once again, we're here for another edition of the Osteopathic Lyceum podcast. Today, we are graced to have as a guest Melissa Biscardi. So what we're going to do, instead of me messing up what I'm going to say, we're going to let you tell us about yourself. So some of your background as far as your healthcare, more or less your healthcare accreditations or certifications, because you have multiple things that would be described with different forms of paper. If that's fair.
Can't stop learning.
Neither can I.
Okay.
But so like I said, I want to give you the opportunity to tell everybody about what you've done instead of me throwing stuff out there and completely leading. So let's start at the beginning with your healthcare.
Sure.
Whatever, your healthcare background.
So I started in nursing, became a registered nurse in 2007. And since you know me, Sam, you would understand how I had an issue with the hierarchy in the hospitals, but I also had a major issue with rotating shifts. So it was not, I was never going to be a hospital nurse, but I want to say I came out of the womb a healer. Like it was just natural for me in the beginning that I ended up in healthcare. So that was a great base. And I worked in reproductive medicine for a while, worked in research, and then I met an osteopath who I actually thought was a physiotherapist.
Yeah, fair enough. Well, depending on who it was, they might have been a physio.
Right, that's true.
They might have had that accreditation prior.
Yes. So I thought he was amazing. And I was like, I want to be like this guy. So that's what led me to osteopathy. And I went to multiple schools, one where we met.
Yep.
And then what else? Oh yeah, I did a little acupuncture certification in there. So I definitely have a lot of tools in my toolbox.
Yes.
Osteopathy led me to really being interested in the brain. And then I did some, again, more like certification type education around applied neuroscience, or that's what we call it, I guess, functional neurology, but some people don't like that term. There's all these nuances with language and there's always someone who doesn't like it. So but essentially I learned how to do active rehab for the brain, and that is really where my passion is. And now I work in concussion care. I'm doing my PhD at U of T, which is looking at interventions for concussion rehab in adults. So it's definitely not been a straight road, but such is life.
I would say that as far as I can tell, it's often better when it's not a particularly straight road, because you recognize the value of overcoming the challenges that present themselves through that. Now you did so to be able to do your PhD, at least in Canada, you have to do your master's first. I don't know that there's many programs that would allow you to kind of do it concurrently, where it's basically you get into a graduate program and you just go straight through to a PhD. So you did your master's at U of T as well, correct?
Yes.
And your master's thesis focused on?
It focused on women post-concussion, and we were looking at the sort of reproductive health outcomes, which are many. Actually, it disrupts the cycle. So looking at that, and we actually did a blood test for anti-Mullerian hormone, which is the hormone that indicates time to menopause. So my sample was 10 people. You can't really say much, but definitely there was stuff going on that could be explored in a larger study, essentially.
Well, one of the things that's probably really interesting about that is if you start with 10 and you see some pattern developing, then that's the beginning of your hypothesis, right? So this is where I end up being quite a stickler, right? There's a difference between gathering data and generating a hypothesis. So gathering data essentially allows you to identify a pattern. From the pattern, you can make a prediction. The prediction is your hypothesis. So it's like, if this pattern holds true, then this should also be true. So then you can formulate your prediction in a way that it can be both tested and falsified. So you should be able to break it if you set up your experiment right. Which is interesting, because I don't know to what degree during your master's you ended up doing much specifically about the philosophy of science. Did you end up doing much specifically about it?
No. If we did, the thing is, it would have been buried in the beginning, where you have your mandatory courses, which you don't necessarily get the most out of.
Sure. Well, you may not be primed to get much out of it.
Right.
Yeah.
So, but I don't think we did. It was more, there was theory, but more system theory, right?
Yeah.
I don't think we did much about the philosophy of science.
And that's totally fair. What that is to me is at least another piece in a pattern that I think I'm observing, that a lot of people who effectively have the title of scientist, they are scientists. They don't necessarily know how it's built from the absolute bedrock. They're very good technicians. They're great on a bench, right? They're great at kind of continuing the work that's already been started, but they may not necessarily know how to build it from the start, which is why, at least for myself, as somebody who was in an interesting position, because where I got my master's in health science education, it's not a discipline, it's a field. So it involves multiple disciplines. So to do that, you have to understand how they're all different and how they all can help build your, essentially, because everything in health science education is applied, right? It's not necessarily, you're also looking at a self-sorted group. You're looking at people who already got through a bunch of filtering mechanisms. So they're all going to do well anyways, right? I don't know many people who are in medical education that just do crap.
Right.
Because they're highly filtered, they're highly sorted. But in order for me to understand what the heck is going on in the research landscape there, I have to have some degree of understanding of how these things are built, how these different worldviews see stuff, the ontologies or the study of reality.
Yes.
And my thesis supervisor ended up giving me essentially an exercise that made me go out and look up the terms related to the philosophy of science. So it's noting that you have your master's and you have you don't have your PhD, you're working on your PhD and haven't necessarily specifically gone through that is another piece in my pattern recognition that it doesn't happen as much as maybe it could. But again, the questions that you're asking and the methodologies that you're utilizing are probably completely appropriate. It's just sometimes it's nice to have maybe a fuller understanding of the bedrock, or at least I think it's nice.
What's really interesting is my thesis supervisor is like incredibly rigorous. So I am getting, but not all of them are, right? No. So I'm getting, I feel like more than what I'm getting what I need, not what I want, right? So she is forcing me, actually, that's a little bit strong, but she really is, to really do what you were saying, actually. So right now we're doing a systematic review, but she will not, we are not moving forward until I can justify every little piece of the intervention that I want to study. But the clinician side of me and the other side of me is like, who cares? We need to study this because it's being done in practice.
So
now, there are two sides of the coin, I feel like, and she's making me a better person, essentially.
Or giving you
a researcher, maybe not a better person.
That's okay. They don't have to go together. There can often be researchers and scientists who are completely disagreeable and absolute jerks, but they do make the world better. Right. And sometimes they're just jerks. So that's totally fair. Just note a systematic review. So I don't remember the specific steps, but there's probably an acronym that corresponds to the steps that you have to do. And I think with systematic review, there's an extension as well on methodology.
It's the Prisma.
Prisma, and then there's a Prisma extension.
Yes.
And are you using the extension?
So I'm trying. I'm sure I am.
It's okay.
But I can't remember what the extension is. Probably has something to do with the analysis part.
Yes. And that's fine. So this isn't necessarily to aim to get caught up in the weeds. It's just to note that there are very, very specified steps that you have to go through. And at least in your case,
methodologies to follow in order to be, she keeps telling me I will be judged by the research world. And so that's it. If you're in the research world, you have to produce things that are appropriate for that world, essentially, whereas which might be different than when you're in a different world.
I would say that that is definitely the case if you're going to go in the direction of publication. If you're going to go in the direction of publication, then you have this really, really interesting thing in peer review. Peer review has this opportunity to be fantastic. However, the way it's done, it was actually, you probably are not aware of this. It was Robert Maxwell. Have you heard the name Ghislaine Maxwell by chance? And Jeffrey Epstein?
Oh, yes, yes, yes.
Jeffrey, the woman that...
Oh, yes, I know them, I know them. Yes, sorry. I was like, I know them. Where can I piece them to?
Her father was a publisher.
Okay.
He was in the publication world. I don't remember the name of the publishing house that he had, but what he did was peer review was already happening kind of in the more like hard science world, and he brought it over to everything else, because what ends up happening is you get all this free labor, this free editing labor.
Interesting.
So the reviewers are,
I thought of it that way, editors. So true.
They're free editors. Then what ends up happening is you get a good editing job done. The publication is basically ideally sifted for accuracy and importance, and then it goes out, but then you sell it back to the library. So you have these people who are not allowed to share their paper with their own university unless their own university pays for it.
Yes.
So now that's kind of an aside that may be interesting for some, not interesting for others, whatever. But it's something that may be of interest to you as somebody who's going in that general direction, at least for a period of time. The peer review process, yes, if you're not necessarily up to the accepted standards or the accepted methodologies, then they kind of kick you out right away, which is something that you can appreciate or hate. Whatever.
You know, it's interesting because when you submit an article for peer review, you can suggest reviewers. So I feel like it does end up being like scratching your back, like I'll scratch your back, you scratch whatever. Yeah. But the other, and you can, I think you can also suggest people that you don't want to review if there's like an obvious conflict of interest or whatever. But then the other thing is sometimes people will end up reviewing your work and they don't really understand it. So when I first submitted my master's thesis for publications, one of the reviewers said that I should have included males.
For a female study. Like you're studying the particular responses for females with respect to
hormone which like is for female menopause.
Yeah, so, I mean, I can joke and say I have manopause or my menstrual cycle, but
yes, it's not quite the same. So it's really the luck of the draw with reviewers.
Yeah, my hormone cycle on a daily basis, female hormone cycle over a much longer basis, depending on the individual female. Yeah, absolutely. Yeah, I have a challenge with what I've identified as what seems to be a political critique in the peer review process, as opposed to an official or an effective technical critique. Because sometimes the reviewers don't understand the methodology properly, so they give you a political critique instead of a technical critique. So instead of maybe dwelling there for too long, what we'll do is maybe shift focus, because there was a reason that I reached out to you. So first of all, actually, before we do that, your clinic is the Concussion Rehab Lab, correct?
Yes, yes.
And that's where everybody can find you. So if you look up Concussion Rehab Lab, not necessarily the rehab lab, it's the Concussion Rehab Lab.
Yeah.
Making sure that people look that up. You are, I would call it somewhere between downtown and midtown Toronto, where you are, right? Most people would that are not from Toronto.
If they're familiar with it, it would be near Casa Loma or in the annex.
Yeah. Now, to me, even though I'm from further north than that, I'm from North York, and people make fun of me for always noting that I'm from North York, but it's personal. I would call that midtown, but some people would call that downtown.
Yes.
Right? You're in a place that's hard to get to no matter what you do.
Exactly.
But your primary clinical focus, your primary clinical focus is obviously on those who are presenting post-concussion. Is that fair?
Yes. Now,
it doesn't mean that you won't work with other populations. It's just that's the population that you're primarily focused on and likely see the most often.
Exactly.
Okay. And a lot of the work that you're doing is informed by all of those tools that you've noted before. So, like as you noted, the nursing background obviously has something to do with it, but the primary tools that you're going to utilize will be the brain specific ones, or the brain rehab ones, or the neural rehab ones, the acupuncture, as well as the osteopathic methodologies. That's fair?
Absolutely.
Right. So basically somebody comes in, you have your way of assessing, you find what you find, and you get to work.
Yes.
Right.
Exactly.
And that's somewhat informed by all of the varying diagnostic approaches. So you've probably tried to coalesce them in some way so that they become more meaningful to you and your patient. That's fair?
Absolutely. And I use a combination of objective measures like eye tracking, force plate for balance, and then subjective report from the patient, and then my observations with my naked eye.
Yeah,
So,
absolutely. Well, the point of observation that you have without, without the other tools, so the force plate and the eye tracking, because the force plate and the eye tracking are mediated through some form of digital interface. That's fair?
Yes, yes.
So essentially you've got the force plate would go into the computer and you get this readout.
Yes.
Right. And
which
then
is a little more precise than what I observed. There's never anything surprising, but it's nice for informing the patient too. Like, this is what your sway looked like.
Yes. Yeah. Well, one of the things that you get the opportunity to do is show something that is agreed upon, right? So, and you know the strengths and the weaknesses of the particular force plate and the particular software and how they interface, and the eye tracking and the particular glasses and the particular camera and all this and that. Like, there's strengths and weaknesses for all of that. Absolutely. But what ends up being important is that you're consistent. You're doing the same thing as a practitioner over and over. So your ability to generate the pattern has more value in your own work.
Absolutely.
Right. That's actually something that has been definitely noted within some, or what I would call very early research. It was 1980. There was an assay of five osteopathic researchers, and what they did, or 5 osteopathic practitioners, and if you look this up, they're all big names. They brought them in, had them assess patients, and they looked at what they were doing with 5 different patients who had predetermined mechanical low back pain, and they all assessed as an individual practitioner, they assessed differently with each patient. So their first level of assessment was one way, they would do some treatment, and then they would assess slightly differently.
Oh, interesting. So their pre-post mechanisms of assessment were different.
Yes.
Okay.
I would say, with what I've seen within the osteopathic profession, that's actually not that strange. Right. I don't know if you would have seen the same thing, but the value of you not being me is that maybe you've seen it, maybe you haven't. Right.
Right.
So have you noticed that? Would you say that's something that you've seen?
So that's interesting. I feel, if I think back to CAO, because that's where I would have observed other clinicians repeatedly. I mean, I feel like we were taught, and in practice, I will do the same assessment pre and post.
Which is a fantastic positive
comment. But it will be a different one that maybe my fellow clinician might choose to do.
Sure. Yeah. So they would choose a different test than you would choose, but their pre-post was the same.
I think so.
Okay. Well,
I feel like it doesn't make sense to have a different one after, but that doesn't mean it's not what's done.
it doesn't make sense for your ability to be valid, but it does make sense if you are of the opinion that you're testing the same thing through a different method.
Right, so that's true.
Right, there's different ways to approach it, but what the nice thing about that is your memory of it is dissimilar to mine in some degree. I would have promoted that. I would have promoted pre-post being the same, but I've seen people do it differently.
Okay.
Right. So the concept that you should be able to test or treat the same thing in all positions.
Oh, right. Yes.
Right. So there's just different ways. Now, the nice thing is that we were in a similar environment and we have mildly different interpretations of what occurred, which is actually good, because then what happens is you start to piece that together and you'll be able to find what's the same and what's different.
Yes. Right?
Yes. So you have your methodology, you have the patterns that you're noticing. Are you consistently in touch with other practitioners who are focusing on concussion?
Oh, definitely. Yes.
Now, do you find that the ways that you're coming to your observations or your meaningful diagnostics have a lot of similarity, some difference, lots of difference?
I would probably say some differences. And this is in part because I have an osteopathic lens, which definitely influences me. It is Now it's becoming more common, but I would say it's more common for concussion care to be physiotherapist, chiropractor run. So
Okay.
I feel like part of it is just I come to it with a different lens,
Sure.
but and with maybe more training.
Sure.
But I would say overall we are looking at the same things.
You're looking at the same phenomenon. Yeah.
We may come to a different priority setting, though.
Sure.
Again, based on our own biases, right?
Well, I have a particular issue with the term bias.
Okay.
This is where it's nitpicky, right? So if you look at the research that generated the concept of cognitive bias, there's this big long list with all these descriptions of specific steps. Have you seen that?
No.
List? Like you can go on Wikipedia and find the list of cognitive biases. But essentially what it is, it's best described as mistakes in thinking that the person doesn't know they're making.
Oh, okay.
So if you don't know you're making a mistake in thinking, what the heck do you do about it?
Right.
So I would delineate a difference between a bias, which is a mistake you don't know you're making, and a preference, something you like.
Okay.
And you do it on purpose, right? So I think a lot of times when people are saying bias, I get the sense that they're really talking about preference.
Yes.
Right. The other thing is that the cognitive biases were built in a particular reference, right? A particular set of views, and a lot of the early stuff was Daniel Kahneman and Amos Tversky. So you can have the positive things to say about that and negative things to say about that. Out of Kahneman and Tversky, you get the type 1 and type 2 thinking, the thinking fast and thinking slow.
Yes. Okay.
And they try to overlay that onto clinical decision making, and it just doesn't work. Like it's just not actually how clinicians function. What you tend to notice is clinician error changes across career with expertise. So you get a general reduction in error with expertise. Now you may get a particular type of error occurring more often later on in a career, but you essentially get better with more knowledge is the best way to put it. So the better way to look at clinical decision making seems to be an expertise model, as opposed to the cognitive bias model. The cognitive bias model doesn't work.
And I was going to say, so for example, there are things that I do in my practice which are associated with consistent results. Whether it's what I'm doing or not, we cannot say, but I see repeatedly over time when certain things are implemented, of course, with individual variation.
Yes.
So then I'm going to do more of that.
Yeah.
Right?
Well, and you're going to see what comes out of it.
And also my weakness, where I really refer out or collaborate, is exercise. We're not taught it in school. I have gotten a little bit of extra continuing education, but when coming to building movement patterns, increasing strength, I need someone else on board. Whereas an athletic therapist who's focusing on concussion rehab, that is really going to be their strength, as opposed to this nuanced manual therapy. So it does, I love to collaborate, and this is exactly why.
Well, I think the nice thing about what you said, to kind of rewind to the beginning of what you were talking about, is you notice a positive range of outcomes with particular interventions. So it's the pattern building, right? You do a similar thing, you notice a range of positive outcomes depending on the particular individual. So you notice that range. So you're kind of like, I'm going to stick here. I'm going to continue to do this up until such a point that it's obvious that it's not going to work. Or what you end up finding is the edge case. So you find a few people where you do that thing and it just goes the complete wrong direction or does nothing. And that forces you into that situation where you have to reconsider and maybe try a different thing. Right. And you've noted, say, something such as exercise possibly being a boundary for you where it's better for you, or you've noted it's better for you, where you've done all the good manual therapy stuff and it hasn't hit. It's like, this is a good time for this person to consider a different modality or a different maybe angle.
Yes.
Right? And that's an expertise model, right? Does that make sense?
Yeah, I like it.
So
I'll take that.
what you're doing is you're learning from notable errors.
Yes.
Right?
Yes.
And what happens over time, have you ever heard the term, this is actually from cognitive bias stuff, have you heard the term experienced utility?
I don't know if I have.
It's okay. So essentially what happens is you do thing A and thing B happens.
Okay,
So you just continue to do thing A, right? You just continue over and over. Now, if there's an error in it that you cannot detect, you just keep doing it.
Right.
Now, what happens is sometimes you get to the situation where the error is meaningful in a particular situation. And so thing B doesn't happen. You do thing A and thing B doesn't happen because it's a mismatch.
Yes.
Because you just keep doing the same thing over and over. And if you don't notice the mismatch and you don't notice, or you're not able to pick apart in some way what the error is, you'll continue to do it and you won't necessarily be in a situation where you can understand it, right? So you'll see that you did thing A and thing B didn't happen, but you'll get to that point. I don't know if you've ever heard it. I've heard a refrain, the treatment was a success, the patient was a failure. Have you heard that?
Oh, I have heard that for sure.
Yeah. Right. So you did the right thing, and that's where you can get.
But that's actually not true. That you didn't do the right thing.
You couldn't have.
Right.
Right. At least if you're looking on the outcome, you could not have done the right thing if it's about the outcome. Right. So yeah, experience utility ends up describing that well. So as much as cognitive bias literature is a nuisance for me, I'm not the biggest fan of it. That's a place where it's really good, right? But the experts, so maybe a good way to do this is to say that what I've noted is that the sin or the mistake of the novice is a mistake of interpretation, because the novice senses everything.
Right. Yes.
They see everything. They just don't think they know what to do with it. Often they do. The expert's problem is a sin of omission. So they do every step until they realize which steps don't really give them anything, so they throw them out, and then they just keep doing what's worked until that time that it doesn't work. They don't know what to bring back in because they threw it all out. Right. So what you're describing is a good expertise model. The only challenge is making sure you don't run into that place where you've omitted things and not bring them back in.
Right. I would say, I'm really fortunate with my education or training that forced me, and I mean that in actually a positive way, to open a book, look at a pathway, right? Like try and understand what is happening and not just apply techniques, even though they are techniques, but you can apply a technique or you can think about why you're applying it or applying an approach. And that mixed with the fact that even though I mostly see concussion patients or some like long COVID patients, those are what make up the most of my practice. They are sufficiently different and complex that I cannot be complacent. So that I would say is one thing that helps me, but I'm of course not perfect, but it keeps me on my toes and learning and seeking out and referring when I understand, wait a minute, I'm not moving the needle on this.
Well, you've got an overall framework that you're working within that you populate the details into, and you know that the people are different enough that you might have to change the details, but the framework is still solid. And then what happens is sometimes you hit the boundaries of that framework and then it's time to refer, right? So again, you've got a really strong expert model that as far as I've seen, I think a lot of people have it, but they're not able to maybe articulate it as accurately, right? So it's good that you've been in those situations where you were forced to figure stuff out and then apply the model over and over again. It's one of the reasons why I like the concept of a heuristic-based model. So I use the term heuristic, and I have this definition that's from artificial intelligence research from 1985. So I don't know if it's been updated. I just like this one. So an algorithm is a set of steps that guarantees a solution, where a heuristic is a set of steps that suggests possible solutions or generates possible solutions. I think that's a better model for human patients, because human patients are not the same, right? And you get paradoxical responders, you get some people, you've probably experienced a range of general outcomes with your patients. Some patients feel like they get run over by a truck no matter what you do. Some patients feel great for a period of time and it comes back. Some people feel nothing, and a few days later they feel different, right? You see the range. It all goes the right direction, but you see the range.
Yes.
And that's why I like a heuristic-based model, or what I term a heuristic-based model. So now I think we've done a pretty good job of identifying that you as a clinician and other clinicians that you know have this kind of expertise model where you have this frame. Within that frame, you notice what works well, you notice a positive range of outcomes for different patients, noting that the different patients are different than one another. So what we want to maybe talk about is what you've noted with respect to that, what you've called the osteopathic lens, say, compared to other practitioners that you know. As you said, there's within the concussion world, or within the world where you see a lot of practitioners dealing with patients with concussions, is you're seeing it more chiro and physio led. And now part of that may just be regulation and the particular location that you and I live, which is Ontario. So
Sure.
what you see is they have the ability to sign for stuff and they're regulated professionals. So you see that. But you noted the osteopathic lens. So what do you, maybe if you can provide a definition of what you think the osteopathic lens happens to be?
That's a good point, right?
Well, because not everybody's going to agree on it.
So one, definitely a holistic approach. So taking into consideration the whole body, which
Sure.
I would say any good clinician should be doing that.
I would agree, yeah.
Right. But paying attention, yes, to the whole body, but also nerve, artery, vein, lymphatic.
Mhm.
And I think taking those into consideration
Sure.
really is more osteopathic. I don't see it as much in
Okay.
physiotherapy, not overtly, at
Sure.
least, right?
Or
And then,
maybe not within the profession at large, but maybe within individual practitioners?
yes.
Okay.
And also the attention to the cranial and the facial tissues.
Okay.
Even some, because of course, you know, I have workshops, etc., and there have been attendees that were unsure if they were allowed to treat those tissues. Like there's a lot of misinformation. Of course, it depends where you are, I'm sure, but if you can treat the neck, you can treat the face and the cranial tissues. So osteopathy is tended to quote unquote own that type of treatment.
Okay.
But now not so much. But I would say still in the osteopathic lens, we tend to it more. So the whole body from toe to head, not just the whole body from toe to neck.
Fair enough. So I think at least I'm aware. Have you ever heard of craniopathy?
No.
It's in it's cranial work for chiros.
Oh, interesting. Okay.
There was a period of time where it was something that would be talked about. Now I don't necessarily know if it's even consistent or has lasted, because what you tend to see is you'll see what would be termed osteopathy in the cranial field, right? Like that's the osteopathy, or like that's the cranial in osteopathy, and then you see craniosacral, which is the upledger stuff, right? So that's for everybody else. So you can think whatever you want of that, but I think the salient point that I think is important from what you said is you noting the neurovascular tissues and you thinking about the neurovascular tissues. So what I've noticed, and feel free to agree or disagree, is that the thing that really differentiates the actual practice of osteopathy from other hands-on professions is the barrier concept. So we have an entire concept that is aimed at not making the patient say ouch. So it's aimed at making the patient not have a meaningful or strong response to what we're doing, whereas other professions as a whole, they don't mind it if the patient has a pain response. Would you think that's fair?
Yes, absolutely. And actually it's interesting because I have had patients ask me to press harder, and I'm like, that you have to go for a massage. Like that is not osteopathy.
Well, so, and I think the way in which, if you want to start to make connections, is that if there is a specific neurological mechanism in relation to the way that an osteopathic practitioner is likely to choose to treat, as governed by the barrier concept, so then you can start to talk about the sensory system, the motor system, and the integration, and you can use a lot of big words. What I would say is most of that's post hoc, or like after the fact, and most of it's from an external observation point, right? So you're not necessarily inside the patient, you don't have anything that would necessarily substantiate the claim, but you have this coming from a good expertise model, as we already noted. You know that when you work on the patient in these ways, you tend to get these results. You know that when you work on the patient in a way that generates a pain response, maybe you don't get that range of results. You're comfortable with that?
Yes. Yes.
Okay. So the thing that
I appreciate you circling and making sure I agree.
Well, it's one of the things that I think that I can present as value is the specific details that I've either come across or that I've interacted with that make me have an angle that maybe other people don't have. I think a lot of people have very, very good clinical behavior. It's just the things that they say are kind of ridiculous, right? You've probably seen me say that or heard me say that in person. Now, I'm not attempting to say that the practitioners are doing bad stuff. I'm saying they're saying ridiculous stuff.
Right.
Right. So
yes.
And
I know you have some pretty strong opinions on this. I don't know if opinion's the right word, but thoughts around treatment in the cranial field, for example, which I am neither here nor there of what's actually happening. Again, I'm on the observation that treating this way provides an effect.
Absolutely. So that standpoint is the one that I'm completely comfortable with. It's when you take it that extra step and you start to make claims, right? That this, that, or the other is happening. I will consistently say, if you look at stuff that I've done focusing on osteopathy in the cranial field, is that the clinical behavior is probably producing a range of results that's positive. It's the claims that are off base, because when you put those claims into a hypothesis or a prediction that can be tested and falsified, it gets falsified. So it's not that the behavior or the outcomes get falsified, it's the claims. Right. So this is happening.
What would you say that, like, okay, so let's pretend it's something else. Let's say it is cooking something, right? So we put some ingredients in and we get a dish, but what we're saying about the middle part is incorrect. Right? Okay. And so what would you say is that piece, the piece that you have found to be falsified? I have watched and listened to your episodes, and one thing I believe I remember correctly is, for example, the movement of the cranial bones. Right? Okay, being at least one of them. What are some other ones that have been falsified, or we don't have enough evidence about the mechanism?
So the two mechanisms that you'll talk about with respect to cranial, at least, would be the movement of the neurocranium, I believe is the proper term, the brain case, right? So the movement of the neurocranium, we understand that at earlier points in the lifespan, they're more patent. The sutures are more patent. Now, you will find edge cases where in adults, you'll have the metopic suture being patent, right? You'll have other sutures that are patent in edge cases. So there are people that exist where those cranial bones will have more movement than other people. But for the most part, they're not patent sutures. They really don't move, right? In any meaningful way that anybody could detect. The other portion is the cerebrospinous fluid and the pulsation of it and the particular path of it. That is, first of all, if you look at the cerebrospinous fluid researchers, the people who are looking at it, there is no agreement on full mechanism for how it pulsates, for how it moves. There's different ones. One is kind of the arterial pulse, basically just reverberating inside that closed case, right? That helps it. There's no specific agreement on where it is, where it's mostly reabsorbed. Production is okay. The arachnoid villi production's okay. The glymphatics is a new description. So you've got all these things that we know we've encountered that we didn't know before, and we wouldn't know from the external environment of observation. Like, we just wouldn't know it. But what we can identify is that the behavior is stable and the outcomes are in a stably positive range, right? So it's the claim about what's happening that I have a problem with, not necessarily the reported outcomes. Now, the claims that have been falsified, as far as, say, the patency of the sutures with consistency and the movement of the cerebrospinous fluid in the way that's claimed by these cranial models, that maybe, how do I want to do this? That can drive the stable behavior. That can be the thing that drives you to be consistent, right? But that's also the measurable thing, right? Or what people would call the quantitatively measurable thing. So the quantitative measurements that are claimed are not there. The subjective measurements likely are, but they're a range. They're not the same. If you work in that way as a clinician, you'll note that not all of your patients report the same outcome. They report a range of outcomes, and you've already said that, right? So I think does that do a good job of kind of where you were pointing, where you were thinking? Okay.
Absolutely. Do you have any thoughts to, and this would be, because you're not doing the research, so it's more like opinion or based on observation. What do you think clinicians are feeling then if they're not feeling the cerebrospinal fluid? Or are you saying you're feeling the reverberation of the arterial pulse?
So I think
thoughts.
Yeah. So I would think that it would be entirely dependent on the individual, because one of the things that we understand about sense data and how it ends up being represented in the brain is that you have essentially a neurological firing of some form that goes into the brain, and the brain is basically completely blind. It's in this dark case. Nothing's happening, or it doesn't have what you would call true full contact with the external world. It gets signals that come in, and then you have to do some interpretive dancing, and you're making a prediction. You're filling a lot of things in. So there's a lot of interpretive steps that occur in relation to sensation. Now, if you're primed with a particular explanation of the sensation, then it's hard to move you off of you're feeling the thing that you say you're feeling. What I would say is the point that I would be comfortable with is you're feeling something, you're sensing something, then you're interpreting it. So to maybe strip it back to what you're actually sensing, I'm not sure. But what I would say that's the most consistent as far as, say, crossover in cycles that I've heard, the PRM, or the primary respiratory mechanism, or the breath of life, or the cerebrospinous fluid pulsing, I think is what do they usually say? 8 to 12 cycles a minute. And then if you look at respiration, you're looking at 6 to 15. Right now, the majority of the time that I see cranial practitioners working, the patient's in supine. You'd agree with that? So a patient in supine has to breathe no matter what. Now, because their head is usually got some negative space, so there's the head is stuck, the thorax is stuck, and the neck is free. You'd agree with that? So every time you breathe, stuff moves. So if your head is in the region of the occiput, or really the superior nuchal line, which isn't actually much of the occiput, again, you'd agree with that? So you're not actually feeling much of the occiput. You're feeling my neck muscles, right? So you're there. So every time you breathe, because you're breathing, everything has to move in relation to what's stuck on the table. So you'll feel some movement referred into the region of the neck that would then refer to your hands at the base of the skull, right? So if you're sitting and waiting, what I would say that the phenomenon, based on the cycles I've seen claim, is most likely just breathing.
Interesting.
Right now. So and the reason I say that is because it's what I'm able to observe. So I have the observation of the claimed cycle. I have an observation of what the people are doing, and I can see some crossover in it. So that's the most likely phenomenon that I would predict. It doesn't mean it's the right one. It's just that's the one that I would trust the most right now.
Yeah, and it's interesting what you say about the perception, like the perception of sensation has to be processed by the clinician's brain. But we know that we can perceive things that do not exist, and we can create perception. So it's actually a huge rabbit hole to go into, but very interesting, right? So, and the practitioners, the truth is we all have lives. And so we will have a state that we enter the office in, and care, emotions or stresses. So it really is, and certainly certain patients that resonate with us more than others. So how does that affect our assessment? It's just, it's interesting. And, in a perfect world, it would not, but we're not technology, so it does.
No, well, you're absolutely, I'm completely on board. So it's all multifactorial. So the perception is based on things you've perceived before or experienced before. So you're making predictions and interpretations based on what you've experienced before, and that is often going to also relate to what people told you you're experiencing, right? So that there's priming. There is, as you say, the impact of a given day or a particular state. It's multifactorial. Because of that, because the practitioner actually ends up bringing so many factors to the table, this is where the philosophy of science ended up becoming really interesting. So you have these two ends of the epistemological spectrum, or the spectrum. Epistemology would be well defined as a theory of knowledge or a theory of truth. I tend to call it a theory of knowledge creation, right? So you have those that believe that knowledge or truth is completely dependent on the individual, the experience, the previous experience of the individual, and the environment of observation. Then you have those that believe that the positivists, so those are the constructivists, they believe it's all individual. And then the positivist believes that there is a singular reality that can be identified with appropriate experimentation, but the people are the problem. So this is where you get the accusation of reductionism. You're reducing it so far and you're taking all the context out. I'm like, well, if you want to actually figure out what the heck is going on that's stable, you do have to take everything out. So what I would say is that thinking is best described by constructivism. It's dependent on the individual, their previous experience, and environment of observation. And that's the practitioner, right? That's because it's hard to get away from that. The positivism, or the shared reality, or the stable reality, is going to be the physical phenomenon that will repeat under certain circumstances. Now, the fact that the patients are different than one another is that variation. So diagnostically, I would say if you're stable, if you diagnose the same way, you'll find stuff, right? Your interpretation is where you run into the problem. So the reason that I advocate for basically acknowledging that our tests are all motion tests and our treatments are all motion treatments is to remove the common location of error, which is the interpretation.
Right.
What I would advocate for is interpret the motion loss to the best of your ability, recognizing that you're a problem as a practitioner, right? So interpret the motion loss, work on the motion loss. And this is actually where you can relate it well to the thing that is claimed that Dr. Still said, but never wrote. He didn't write it. I think somebody, I don't remember who wrote it as a quote from Still, but the find it, fix it, fix it, leave it alone. And then nature will kindly take care of the rest. So to whatever degree the motion problem you identify and interface with and prove change by using the same test, so your test and retest are the same, to whatever degree that mechanical observable reality shifts, to whatever degree it relates to the problem that the person is presenting with, it will change. Right. To whatever degree it's not related, the movement will be better, but the other thing won't change.
Right.
And that's where, so it's a description of the phenomenon that you're noting, where you're usually getting positive results. Now you're not getting positive results. I'm going to refer because I'm at the limit of what I know how to do. Right. So again, I think the way in which I describe it strips a lot of the interpretation out. And matches well with exactly what you're already doing, and matches well with an expertise model that I would say most clinicians are doing, just not maybe good at describing.
Right. Yeah, absolutely.
Right. So, because one of the things in the email chain back and forth between you and I before doing this is you noted that you may disagree with me on some of the mechanism stuff, right? Which is absolutely fine, because if you disagree with me, if you have a piece of information that I don't have, you can share it with me, and then I can use it to update. So does it shift my prediction? Does it shift my understanding? Does it have enough problems with it, the piece of information that you might share, that there's so many problems with it that it can't shift me, right? It's better to have that out and communicate it.
Yeah, absolutely.
But I mean, so far, and I don't know if you'd agree with this, I think maybe in the discussion that we've had so far, the way that I'm describing it, or things that you've already heard me say, end up matching really well with what you're already doing.
Yes. Yeah. I would agree.
Yeah. And you're not necessarily somebody who's stuck on mechanism. And part of that's probably because you've seen enough things in a rigorous lens that haven't necessarily held up to scrutiny. So you have to kind of shift. Right. Is that fair?
Yes, absolutely. Absolutely.
Yeah. So it's the thing that I find interesting is that, at least in my experience of discussions that haven't been recorded with practitioners, is that I've found some who are firm on their view, right? But very few people who I actually have discussions with really deeply disagree with the angle that I'm coming from. And I think one of the reasons there is because I'm doing that positivist thing, or that traditional thing where there is a stable reality. It can be identified. You just have to remove a lot of the interpretive dance, the personal flair. Most people seem to actually be doing that, and most people, they'll have their explanation of it, but the work is really good. So the explanation is what falls apart, but the work is really good.
Yes.
And as you've already noted, you're finding that in your actual practice, right? Which is awesome.
And what was I going to say? I think so. One area I thought we might disagree. I don't even know if we've touched on it yet,
Sure.
but not so much on the mechanism, but more. I mean, I can't imagine we would disagree, but what is it? Like, if there's not research on it, that doesn't mean it doesn't work.
No.
And this is where I have like such a huge problem more with the research world and practitioners who are like, where's the research, which is what fueled some of our contact. But it doesn't mean it doesn't work. And actually, this is maybe lends itself to the whole mechanism of action, but also being just a curious practitioner. And right now I just keep writing dig on, and it's like, do some work, because not everything is going to be fed to you. Right?
No. So I think I would say there's going to be no disagreement. What I would say is that the vast majority of what occurs as far as the ability to identify or generate a pattern that is through observation. So the practitioner, the clinician, is in contact with patients, doing fairly stable things, getting a fairly stable range of outcomes. Again, not the exact same outcome, but a range of outcomes.
Right.
For a researcher, or for somebody to say, well, there's nothing proving that, is where I would say
responsible, actually.
Yeah, but this is where I would actually note the value of the philosophy of science, right? That the person who's going to make that claim doesn't understand data collection, pattern recognition, leading to a hypothesis, and then testing. So the hypothetical deductive method, which, if you want to look this up, essentially is well described by Karl Popper, but you're not going to find it in one thing that Karl Popper wrote. It's diffuse. But the hypothetical deductive model versus an inductive model, right? So the hypothetical deductive model is, you see a pattern, you make a prediction, you generate a test that should be able to break your prediction. So it's like, if this is true, then when I do this, I should see this. And then if you don't see it, you have to accept the null hypothesis. So for somebody to say that a practitioner seeing a consistent range of outcomes is not acceptable, what I would say is, if the practitioner makes a claim as this is working because, that's a problem.
Right.
If the practitioner presents it as this is what I'm seeing consistently, then the person who's interested in the hypothetical deductive model or interested in research or experiment should say, interesting pattern. Let's see if we can work together and generate a prediction and try to break it together. Right? That's what I would say is more responsible. But often what you'll see is people feeding their own
egos.
Well, not even egos, but feeding their own incentive structure. So the incentive structure of a researcher is to protect the rigor, to protect what they view as the world of rigor. Now, if you're trying to protect the world of rigor, the best way to do it is rigorously, as opposed to just saying you're doing it wrong. It's like, well, clinicians are the ones who generate the patterns. At least with respect to research into healthcare, they generate the patterns because they're the touch point between the patient, who's the end user of all the skills, and everything else. So yeah, it's fairly irresponsible. So so what I'm going to do, because my camera's about to die, right? So what I'm going to do is I'm going to thank you very much. So stay on the line just after my camera dies, because I'll switch over to the other one. But we'll wrap up the discussion and say, basically, the point that you thought we disagree on, we don't disagree on.
Yes.
Which is why I think, of course, I think I'm on the right track with a lot of stuff, but it's why I'm trying to share it and why I'm trying to have discussions with varying people who will fit the model or make me shift my model. All right. So I really thank you for having the discussion with me. And I want to say everybody should find you. I will make sure that at some point in the video that we have, and the links, we have links to you and your work, which also should link to some of the workshops that you do. So thank you very much. Perfect. And hopefully that was useful to some people, and we will see you soon. So, blah, 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 blah.